Okay. So in the lifestyle modification, they ask in CDM question that you might need to do like in a physical activity, what you need to do, advise a person to take the 150 minute of the moderate intensity per walk, like talk, exercise, and then absolute contraindication. This is very important. You need to know when are you going to tell that person that they don't need to do any physical activity. Which conditions are those ones? Like ruptured membrane, preterm labor, hypertensive disorder of the pregnancy, incomplete cervix, IUGR, multiple gestation, or placenta previa, persistent T2 and T3 bleeding, uncontrolled type 1 diabetes mellitus, uncontrolled thyroid diseases, cardiovascular, respiratory, and other. So in these conditions, you are going to ask the female to avoid the physical activity. So this one. Just know the absolute one. Relative indications, if you can remember it, it's okay. If you cannot, then it's totally fine as well. Weight gain, optimal gain is okay. How much is the optimal? Varies from 6.8 to 18.2 kg. Work is basically strenuous exercise, extended hours on those ones. Air travel, sexual intercourse, you can advise them if there is a spontaneous abortion, preterm labor, or placenta previa, you can advise them to refrain. Now they can ask you a question if she's working in a certain type of environment and she's asking you to give her off or ask you to give her a preterm, sorry, some they ask to make a medical notice so she can apply for the vacations or she can ask for a medical leave. In those conditions, you are still going to assess if this person still needs like having a placenta previa or multiple gestation or what kind of working environment is where she is working. After confirming all of those things, then you can advise that person to do the so then you can advise a person to do the uh, medical notice or medical leave. Otherwise, you are not going to give the medical leave because you are at the family physician. So you are a family physician, so you cannot give the person to take the leave without any particular reason. So that's why you have to make sure that working environment is okay and she has certain type of conditions where she needs to take the leave. That's why after that you can confirm that she needs to take the leave and still you are going to refer that person to go to the obstetrician and ask for the further point of view. But let's suppose if that's not in the option, then you can give as a family physician, you can give the medical leave. Now smoking, and obviously you are going to ask that person to quit smoking. If she does not want to quit smoking, you can always tell the alternatives by using the bupropion or vernicline during pregnancy. But at the same time, you can advise the person to go for the rehabilitation uh, societies where they help to quit the smoking. But as you already know that in the Canada, there is no law for the fetus who is already in the mother womb. So in that condition, you are not going to ask the mother to quit smoking by force, right? You can always advise in every visit, you can keep on advising, but you cannot just force her that this is against the law or something like that. You can just give the advice. That's it, or encourage or assist to quit smoking. Alcohol, no amount of alcohol is safe in pregnancy. Cocaine, same goes for cocaine. Cannabis, same goes for cannabis. And then biophysical consideration, discuss the adjustment to the pregnancy, like mood, stress, working, family, and all of those things. As I told you in the work, you have to make sure that she needs the medical advice or medical leave. Then you can give the medical notice. Otherwise, you cannot. Or you can just always advise she can apply for the non-pay leave, right? So because if you give the medical notice or for that person to take the leave, she needs to get the like it's paid. So that's why you are still in the liability condition where you have to make sure everything. Then birth plan, refer to counseling and the community resources as necessary. So you can provide all of those things. Medication, just remember this one if you can, because in MCQs, they can ask you if somebody is taking NSAID, what could the complications be? Ductus arteriosus, misoprostol, Mobius syndrome, lithium abstin. So these ones. Coming to immunization, what are those immunization? So postpartum and intrapartum. In intrapartum, we don't give live vaccinations. In postpartum, we do give live vaccination. So administration dependent on the risk of the infection. Safe is tetanus, diphtheria, influenza, hepatitis B, and pertussis. Now you need to remember when are you going to give which vaccination at certain type of the gestational week. Avoid the live vaccinations, contraindicated oral typhoid, and then Public Health Agency of the Canada recommends all female receive the influenza vaccination, so they can receive it. All pregnant women should take the Tdap every pregnancy, irrespective of the immunization history. So especially in the 27 to 32 week. And postpartum, all the live vaccination like rubella, measles, mumps, or whatever the needed is. Hepatitis B should be given to the infants within 12 hours of the birth, and if maternal status unknown, so this is important. So maternal status is unknown or positive if the father is known to have a chronic hepatitis B. Follow-up doses at 1 and 6 months. So in the certain conditions, what are those conditions? If the maternal status for the hepatitis B is unknown, or it's positive, or the father has the chronic hepatitis B, in those conditions you need to give the other two hepatitis vaccination as well. Otherwise, only the 12 hour after birth the hepatitis B vaccination should be given. Delayed postpartum vaccination is recommended if the patient receives immunoglobulin or the blood products. Radiation, you can skip this one. Coming to the antepartum hemorrhage, the differential diagnosis, same placenta previa, abruption, vasa previa, cervical lesion, and then uterine rupture, all of those things. What are the placenta previa and placental abruption? Placenta previa is where the placental location is just near and partially or completely over the internal os. But in the abruptio placenta, there is a premature separation, especially after 20 weeks. This 20 week is everything. Okay. Then this is idiopathic as well. What happens in the history of placenta previa? Or multiparity, increased maternal hemorrhage, or increased maternal age, or multiple gestation, uterine tumor, or uterine scar that could lead towards the placenta previa. Placental abruption, there is like some sort of rapid decompression of the distended uterus. So they're kind of trauma history, multiparity, the age factor, cigarette smoking, maternal hypertension is one of the most common one, and previous abruption could be the cause. Trauma is one of the most common cause because a lot of people miss this one. Uterine anomaly and the fibroids are also. So previous painless and abruptio placenta is usually painful. It could be painless as well. So don't go with the painful and painless only. Placenta previa, as we already discussed, there is a painless red vaginal bleeding. Mean onset of the bleeding is 30-week gestational age. Do not perform the digital vaginal exam until placenta previa is ruled out. Uterus soft and non-tender, presenting fetal part high and displaced, fetal heart rate usually normal, and then shock and anemia corresponds. Complication depends on mortality, prematurity, intrauterine hypoxia, malpresentation, preprom. So leads toward all of those things where the blood is compromised, leading towards the fetus having less supply of the blood. So hypoxia, malpresentation, prematurity, death is these are the things. But in maternal, all of the hypovolemic shock, because the bleeding is there, so the shock could be one of the most important thing. Then placenta accreta and hysterectomy could be needed. Then coming to the investigations, you are going to start with the transvaginal ultrasound is more accurate than transabdominal, because on that way you can find out if the placenta is just right above the os or not. Then spontaneous resolution could be there, is likely with the increased uterine distension. And then transvaginal ultrasound should be repeated in the T3 because the placenta location keep on changing. That's why I said you need to make sure that the placenta is in the accurate position by the T3, by the trimester 3. Coming to the goal, the pregnancy, obviously the goal is keeping the pregnancy in the intrauterine as much as possible, and making sure the risk and outcomes or whatever is happening is ruled out. Stabilize and monitor the mother more than fetus. Obviously, you are going to stabilize the fetus as well, but mother stabilization by making the circulation or hemodynamical stability is more important than doing anything else. So maternal stabilization, large bore IV, giving fluids, oxygen, vital, urine output, blood volume. So these are all the monitoring you are going to do. External fetal monitoring is important. Ultrasound assessment to make sure that the fetus is okay in that, and then fetal viability, gestational age, and then placental location. Then ROGAM. If they ask for one of the most important thing after stabilization of the mother, the next thing would be ROGAM. Then flow cytometry and clear Betke to make sure if there is a more, ROGAM is needed or not. Then if this is less than 37 week, admit the hospital, limited physical activity, corticosteroids for the lung maturity, because anytime the delivery could happen, and deliver when the fetus is mature or the hemorrhage indicated. So then you are going to deliver. And after 7 week, definitely cesarean delivery. Not the normal delivery, cesarean delivery, deliver by the cesarean. Okay. Placental abruption. So classification is total, external, and internal. Depending on these ones, the presentation could be different. So usually it's painful, so we go with the painful. They don't give in the scenario like in MCC questions where there is controversy. So if they want you to make a diagnosis like right away, like making the diagnosis of placental abruption, they would usually give you the painful history. Like it says there's this 80% of the chances, so usually they give you the 80% of the painful one. Then painful vaginal bleeding, uterine tenderness, contraction, and hypertonus pain, sudden and constant and localized. So the shock, anemia out of proportion, fetal distress, fetal demise, and then bloody amniotic fluid can lead you toward the thinking of the placental abruption. And then coagulability. So you have to make sure PT and APTT has been done. Complication, fetal complications, prenatal mortality 25 to 60%, maternal complication less than 1% of the maternal mortality, acute renal failure, anemia, and then hemorrhage, shock, or pituitary necrosis. Coming to the investigation, what are the first thing first? Clinical diagnosis. You don't need to do anything else. But let's suppose if you are still not sure, you can go for the ultrasound, but ultrasound is not that sensitive. Knowing that this is painful, having the bleeding, having a history of trauma, this can lead towards the placental abruption. That's it. Then you are going to start with the maternal stabilization. As I already told you, maternal stabilization is more important than anything else. Then after doing that stabilization by giving fluids, you are going to go with the monitoring by doing the vitals, urine output, blood work, fibrinogen, so all of those things. Then external fetal monitoring, blood products on the hand. What are those blood products that needed? Red cells, platelets, cryoprecipitate. Why? Because the bleeding is happening and the patient could go towards the shock. So that's why. Rogam, you are going to do and cyclometry and clear Betke to confirm if the Rogam dose was enough. If this is 37 week, if this is less than 37 week, you are going to keep the fetus in the womb as much as possible and then, try to stabilize the mother. But if this is more than 37 weeks, stabilize and deliver. And they did not mention that you need to do only the CD. So you can deliver with normal, normal vaginal delivery depends on the condition of the mother. Abruption with the fetal and the maternal compromise, hydrate and restore vaginal delivery info. If no contraindication, if there is no contraindication, you can still go with the vaginal delivery. But in placenta previa, we go with the cesarean delivery. Cesarean delivery, if live fetus and the fetus or the intrauterine compromise distress develops with a fluid or blood replacement, there is still like compromise and you want to save it, then definitely you are going to go with the CD, cesarean delivery. Vasa previa, as it's the painless vaginal bleeding and very rare, higher in the twin pregnancies, is kind of very uncommon. So that's why we don't usually do that one. So you can do APT testing or right test on the blood smear to find out, and usually we go for the planned cesarean delivery. Coming to the preterm labor is one of the common complication of STIs, especially the bacterial vaginosis, as we already discussed this one. So it could be the most important is infection, HTN, diabetes mellitus, chronic illness or mechanical factors, so all of these ones, social factors, preeclampsia and advanced reproductive age. Maternal factors are PPROM or polyhydramnios or all of those conditions. Fetal, multiple gestation and congenital anomalies. Uterine, all of those enlargements can lead towards the preterm labor. So most important things are the risk factors. They can ask you in the CDM question, what was the risk factors? So as they said, prior history is one of the important things. Prior history of the multiple excision, cervical excision, they can lead towards the cervical length is important. So identification of the bacterial vaginosis, as I told you, bacterial vaginosis could lead towards the preterm labor. That's one of the most important thing. And routine screening, we don't do routine screening, but if there is any symptoms, then we definitely go for it. As they said, routine screening not supported by the current data. So that's why depending on the patient who is like living in the in a socio-economic status where they need this screening, then you are going to definitely do the screening. So family history of preterm birth, smoking, late maternal age, multiple gestation, and cocaine is one of the things. What are you going to do? First thing first, cervical cerclage, progesterone, lifestyle modification. Starting with the lifestyle modification, going to progesterone, and then go for cervical cerclage. But depends on if the condition is very severe and you need to do the cerclage right away. So definitely we are going to do. So the placement of the cervical sutures at the level of the internal os, usually at the end of the T1 and T2 and removed in the T3. So when are you going to do is basically at the end of T1 and in the start of T2, trimester 1 and trimester 2. So indication cervical incompetence, where you find this is a dilation and effacement, you are going to do that. So obstetrical history may be silent cervical dilation, recurrent T2 losses. So that's what lead towards the cervical incompetence, where there is no history or there is a silent cervical dilation. So just, doctor, I don't know what happened. So it just already happened. So that's why there is no certain history. So that's why it could be the cause is cervical incompetence. Ability of the cervical cervix, ability of the cervix to hold on the inflated Foley's catheter. You're going to check by checking the, putting the Foley's catheter in the cervix. And then transvaginal ultrasound can lead towards the finding of cervical length. High risk pregnancy only before 28 weeks. So this 28 week is everything. So you need to know this could be done in 28 before 28 week. Proven benefit in the prevention of preterm labor. So that's why we do it. In progesterone, we are going to give the progesterone thought to maintain the uterine quiescence, and exact mechanism is unknown. So all you need to know is what are you going to do is cervical cerclage. When are you going to do 28 week? Progesterone, when are you going to give is basically 16 to 20 week gestational age, vaginally starting at the 16 to 20 week. Now, lifestyle modification, definitely this is going to be done in the every single scenario. Smoking cessation, substance use, or GU infection, and then pet patient education. So starting from that one, going to progesterone in 16 to 20 week, and before 28 week, you can give the cervical cerclage. That's what you need to know. Then predicting preterm labor, positive is more than that, and negative is that one. Contraindication are those ones in cerclage. So predicting preterm labor is basically when is it contraindicated? Usually it's contraindicated when cerclage is done. Then you are not going to do anything like, there is a vaginal bleeding or exam, because then it comes in false negative. Clinical features are regular contractions and then cervix more than 1 centimeter. What is the management? So these were the prevention of the preterm labor. Okay. So the management, let's suppose this is already started, transfer to the appropriate facility if stable. Like let's suppose if she's just in the midwife care, or if she's in the clinic. So first thing first, transfer to the appropriate facility, like transferring to the hospital. Tocolysis should be done. First dose of antenatal steroids should be given. Now, what is tocolysis? So starting with the hydration, bed rest, analgesics, avoid repeated pelvic exam. It's very important because it can increase the risk of infection. So they can ask you what is the one thing that you would avoid in this person. Repeated physical exam. Ultrasound management, examination of the ultrasound examination of the fetus to find out the GA, BPP, and presentation, placental location, and the external fetal volume. External fetal weight. Then prophylactic antibiotics are given, considered if the PPROM has been done. Tocolysis. Now, what is tocolysis? Suppression of the labor by doing what? These management started when the preterm labor has been already started. Prevention is only done when you feel like that this person can go to preterm labor. In which cases, when you feel like there is a previous history, there is a history of infection, in those conditions, we do prevention. But in the management, like the patient has already undergone to preterm labor, then we do the management. And in management, we start with the initial, like doing hydration, transferring to the proper care, giving steroid, because that's what you need to do right away. So tocolysis does not inhibit preterm labor completely, but can give you the time to give steroid to mature the lung. That's it. So, but may delay delivery to allow for the betamethasone. And which steroid is given? Betamethasone. It's important because they can give you dexamethasone, prednisolone. Which steroid can be given? So betamethasone. Validate or transfer to appropriate center for the care of the premature infant. And then requirement is preterm labor, live. So when are you going to do this one? Almost satisfied. Live and immature fetus. If the baby is dead or demise, then you are not going to do the tocolysis. Absence of the maternal and the fetal contraindication, then you are going to see what are the contraindications. If there is a bleeding, maternal disease, or the preeclampsia, because in this condition, we are going to use a check calcium channel blocker or prostaglandin. That's why you are going to make sure that the patient female is not bleeding, then there is no preeclampsia. Dioreo amniotic, amniotic. Then the erythroblastosis fetalis and the fetal distress in ICU. In those conditions, you are not going to do the lipolysis. Starting with the calcium channel blocker, nifedipine you are going to give, then prostaglandin. Uh, Relative contraindication, absolute contraindication is basically CHF, maternal CHF, and aortic stenosis. That's it. Prostaglandin contraindications is hepatic impairment and the peptic ulcer disease. You don't need to know the the dosage or when are you going to give and how much you are going to give. Then antenatal corticosteroids, betamethasone you are going to give. So the corticosteroid dose and time period is important. Okay. So you're going to give 2 doses every 24 hour or every 4 hourly, every 12 hourly for 4 doses. So just remember this one, the first one. Every 24 hours, you're going to give 2 doses of 12 mg. That's it. Give between 24 to 34 week. This is important. Please remember this one. The age. Age, when are you going to give this one? Given between 24 to 34 week. If expected to deliver in the next 7 days. Patient between 22 and 23 week at high risk of preterm within next 7 days should be provided with a multidisciplinary consultation. So the person or the patient who is having 24 to 23 week at high risk of preterm labor, multidisciplinary approach means obstetrical consultation, midwife consultation, along with family physician consultation. So all of these multidisciplinary consultations regarding high likelihood for severe prenatal morbidity and mortality and then maternal mortality, and consider antenatal corticosteroid therapy if early intensive care is requested and planned. Specific maternal contraindications is including TB. So if the female is having TB, you are not going to give corticosteroids. Just remember this one. And what it does is basically enhance the fetal lung maturity, all this. Now neuroprotection MGSO4. So 4 things you are going to do in tocolysis, starting with the steroid, giving nifedipine or either endomethacin. So you can give both of them, either of them, sorry. Either nifedipine, either endomethacin. Then corticosteroids, fetal lung maturity, you are going to check. And let's suppose in the scenario you have to write down the management. You are going to start with the transfer to the facility, right? Starting with tocolysis by giving nifedipine, then moving to the corticosteroid, and then MGSO4. So these are the 4 things. The prematurity is the leading cause of the prenatal morbidity. Pre-labor rupture of membrane, like PROM. So in the PROM, this time is important. More than 18-hour elapsed between the PROM and the onset of the labor. So this is a prolonged one. The pre-PROM is basically before 37 week, and along with the PROM is happening, like more than 18 hour has been spent after the rupture of the membrane. Risk factors is multiparity, cervical incompetence, infection, family history, low socioeconomics, class, and the poor nutrition. Congenital anomaly and multiple gestation are the risk factors associated with the preterm labor. So clinical features is including the sudden gush of the fluid or continued leakage from the vaginal area. And then investigation is sterile speculum. Usually we don't do it because we are not sure. So if we do the speculum examination and we ended up rupturing the membrane, which was already intact, so that's why it's kind of avoided. Then nitrazine test is done, low specificity, even though we can avoid this one. Then furning salt in the amniotic fluid evaporates. Ultrasound to rule out the fetal anomalies. So usually we go with the ultrasound. That's kind of safe and help you to find out if the membrane is there or not. Prematurity increases newborn risk of respiratory distress, hypoglycemia. So hypoglycemia is one of the most important thing, because after the birth, the first thing the child could experience is seizure, which could be caused by hypoglycemia or hypocalcemia. That's why. Hyperbilirubinemia, anemia, apnea, feeding difficulties, seizures. So that's why. Membrane status determined by pooling of the fluid, increased pH or vaginal fluid, firming of the fluid under light microscopy, and decrease of amniotic fluid volume on the ultrasound. So ultrasound can help you to find out the amniotic fluid volume. This can lead towards the finding of the pre-labor rupture of membrane. Management is avoid for the expectant admit for the expectant management and monitor vitals every 4 hourly. You are going to do the daily NST, WBC count because to find out if there is an infection. Surveillance for the infection. Avoid introducing infection by doing a minimal examination. So then consider administration of the dexamethasone, like you can give it if the to accelerate the maturity if this is less than 35 weeks. As we already discussed, it should be given before 35 weeks. Screen for UTIs, STIs, GBS. So make sure you already rule out and treat with antibiotics. If not in the labor or the labor is not indicated, consider antibiotics like penicillin or macrolide antibiotics and then deliver urgently if the fetal is in the distress. Prom management, so based on the age, gestational age. If this is 25 to 20, 22 to 25, individual consideration with the counseling of the parents. So in the certain early age, all you need to do is counseling. In up to 34-week, you can do is basically avoid the complications as much as possible. 34 to 36 is gray zone where the death can be happened because of RDS, respiratory distress syndrome, or neonatal sepsis, and more than 37-week induction of labor. So deliver as soon as possible to avoid the sepsis. Post-term delivery pregnancy, you can remember it because it's more than 41 week. All you need to do is the management is basically induction of the labor. Just deliver it. If no contraindication to the vaginal delivery. Coming to the intrauterine fetal demise, the baby is already dead. What could be the causes of it? So knowing the risk factors is more important than anything else. Then what happened is basically the fetus is not growing, fetus is not moving, so mother can present with these kind of things, or the weight of mother is not increasing, and then you can go for the fetal doppler, which is not basically diagnostic. Only knowing on the ultrasound can help you to find out. So on ultrasound, no fetal heart rate depending on the lining of the death, and maybe sorry timing of the death, and may see the skull collapse. So these things. Poor visualization of the midline phalanx, so these things can help. What are you going to do? Obviously, deliver the baby right away because it can lead towards just sepsis. So secondary causes should be ruled out, like HbA1c, like all the diabetes, hypertension, CBC, all. So you need these all need thing these all things should be excluded. So for the further future pregnancy. Fetal karyotyping or maybe skin biopsy needed, autopsy can be done, amniotic fluid. Now, this is an ethical question. What happened is if the female is coming to you and she said, my fetus or my baby in the womb is not moving from last night, and you did ultrasound and there is no fetal heart rate, and you already declared that the baby is dead or the fetus is dead in the womb, what is the next thing you are going to do? Are you going to deliver it right away? So basically, what we do in this condition is we are going to give mother some time to spend with the fetus, which is already in the womb, because you never know, she might be attached with it, and she's going through something psychologically. So that's why you have to do the counseling and ask them to spend some time with the fetus, and meanwhile you can plan the delivery. So this is how you are going to attempt the question. First thing first, their mental health is more important than anything else. Treatment IUL with the vaginal misoprostol monitor for the maternal coagulability. Paternal psychological care is everything. Bereavement support as per the hospital protocol. Comprehensive discussion within 3 months about the final investment and the postmortem results help make plan for the future pregnancy. So first thing first, you are going to start with the psychological care and the bereavement support, then doing the induction of labor. Intrauterine growth restriction, failure of the fetus to reach its biological determined growth potential due to the pathological factors. Risk factors are everything you need to know: smoking, drug use, alcoholism, cyanotic. So most important is smoking. They are allowed these kind of questions. Hypertension is one of the most common cause. So what happened is in hypertension, macrosomia and IUGR both happened, but most importantly IUGR. Okay. Then placental insufficiency can lead towards the IUGR. Torch infections can lead toward the IUGR, or chromosomal abnormalities can lead towards the IUGR. What is the first thing? Symmetrical or asymmetrical? Symmetrical occurs early in the pregnancy and asymmetrical is late in the pregnancy. So the most complicated one is symmetrical early in the pregnancy, because what happened is organogenesis is happening in the start, right? So in asymmetrical is more favorable prognosis than the type 1. Why? Because organogenesis has been already happened. So there is no problem with the organs. Only the body proportion is increasing. So that's why asymmetrical has chances of living or surviving more than symmetrical one. Okay. If they ask in the question, which one is the has more survival chances, asymmetrical has more survival chances. Complication is meconium aspiration, polycythemia, or hypoglycemia, hypocalcemia, hypophosphatemia. So these things, all of the hypo things could be there. Hyponatremia and intellectual disability. Symphysis fundal height measurement should be done in every visit. Ultrasound for the biparietal diameters to find out if it's already IUGR or there is a miscalculation of the dates. BPP or Doppler analysis for the umbilical cord, because maybe the supply of the blood to the fetus is not going properly. Management prevention via the risk factors prior to the pregnancy is ideal. Then modify the controllable factors like smoking, alcohol, treat maternal illness like HTN, hypertension or diabetes or anything that could be there. Serial BPCP should be done in every visit to determine the cause of IUGR. Then delivery when the extra fetus is better than internal one. So you have to do the delivery. Especially if there is more than 34 week, you can do the delivery. Optimal fetus with the beta-methasone, as they already said, it should be done before 35 or as IUGR fetuses are less likely to withstand stresses of the labor, they are more likely to be delivered by the cesarean delivery because the baby is very small. They cannot go through that much stress. Macrosomia happens usually with the diabetes mellitus. So prevent hyperglycemia, and the most important is their complication. What happened in the complication is basically baby who presented of who is macrosomia and delivered through gestational diabetic mother experience hypoglycemia and can present with seizures. So that's why hypoglycemia is one of the most common complication in the fetus after after being born from the gestational diabetic mother. So prevention is basically hyperglycemia in the patient with the diabetes, optimize prenatal, and then plan cesarean delivery because the fetus size is so big, it's very unusual if you can do the vaginal delivery. Polyhydramnios and oligohydramnios. Polyhydramnios, just know the etiology, what are the common causes of it, as chorioangiomas, multiple gestation. Multiple gestation is one of the most common one, and fetal hydrops is one of the most common one. And then fetal chromosomal anomaly, and then tracheoesophageal fistula, duodenal atresia, and then facial clefts. So these kind of stupid questions they ask in the MCQs. Oligohydramnios in the maternal uteroplacental insufficiency, medications, fetal congenital urinary tract infection could be the cause. So usually in the oligohydramnios, there is a problem with the urinary system. Just remember this one. This can help you to remember the etiology or the risk factors. Ruptured membrane can also be the cause of oligohydramnios, and the amniotic fluid normally decreases after 35 weeks. That is also cause. Then coming to the clinical features, the clinical features is pressure symptoms. Why? Because amniotic fluid is too much, so causing to the dyspnea, edema, and hydronephrosis or obstetrical complications leading towards the any part of the fetus or placenta can be pushed out because of the pressure. So cord prolapse, placental abruption, malpresentation, preterm labor. So uterine dysfunction. Inside the pressure is too much, so they can push the cord outside, or preterm labor could happen, or placental abruption could happen. In the oligohydramnios, what happen is fetal anomalies because there is not enough movement fluid for the fetus to move. So they might have this limb anomalies or porter faces or the abdominal wall defects. In the obstetrical complication, the cord compression because not enough space or not enough space for the movement. So that's why the cord compression can happen, or adverse fetal outcomes because they are not moving freely. Management is, if this is too much fluid, you are going to take out some of the fluid. So screening should be done to find out if there is any disease. Depend on the severity. If there is too much, you can do amniocentesis to remove some of the fluid. But if this is an oligo, so you have to make sure the hydration status is normal. Of membrane, fetal monitoring could be done, ultrasound Doppler, and maternal hydration. Maybe the fluid is not enough. Injection of the fluid via amniocentesis, and then consider the delivery if term amnio infusion can be considered during labor, depending on the need. Then prognosis, what happen is mostly 2 to 5 fold increase in the risk of the prenatal mortality. So amniocentesis, polyhydramnios can lead towards 2 to 5 times mortality. Antenatal depression, yes, antenatal depression. Major depression occurs in the patient who is pregnant. All you need to remember is how are you going to do the assessment and treatment. Edinburgh postnatal depression scale can be used. And what are you going to prescribe is antidepressant, because this is antenatal. All you need to do is antidepressant, which is safe in pregnancy. Psychotherapy, sportive care, electroconvulsive therapy can be done. And then psychosis, catatonia. So usually we start with these ones. High risk of suicide. So if there is high risk of suicide, you might need to admit this patient. Food refusal leading to dehydration. So might need to admit it and correct the hydration status. May be associated with altered fetal physiological effects, adverse pregnancy, or neonatal outcomes. So anything can happen, or might lead towards the abortion. Psychopathology leading to the lasting long-term effects. Now coming to the multi-fetal gestational malpresentation. So management is important. Otherwise, it's just this is a malpresentation. So just management, because in MCQs they can ask this. Ultrasound determinants of the chronicity must be done with the trimester one, just to ultrasound to make sure how much placenta is there, how many, what is the position of the placenta. So all of these things may attempt vaginal delivery depending on what kind of it. So the question they can ask from this one is usually if chorionic diamniotic, what is the mode of the delivery. That is the most important thing they can ask. That's it. So usually in dichorionic, diamniotic, monochorionic, diamniotic, we go for vaginal delivery, and in monochorionic, monoamniotic, we go for cesarean delivery. That's it. As you can see from here, how does they look like? So just see the picture of them. They can ask you by giving the picture, what is the mode of delivery for this one. Twin to twin transfusion usually detected by ultrasound screening. What do you do is fetoscopic laser ablation to separate them, and then therapeutic serial amniocentesis to decompress the polyhydramnios. Intrauterine blood transfusion to donor twin if necessary. Breech presentation, extracephalic version we do, and what is a contraindication of those ones. That's important than anything else. So absolute contraindication is where cesarean delivery is required, like having placenta previa, previous myomectomy has been done, prom has or multiple gestation. So these are the absolute contraindications. No need to remember.